You guys, I'm really excited. We just created all this amazing merch. And so if you're loving the podcast and you want to support our cause and continue to hear amazing episodes, please support us by buying some merch. I am living in these sweatshirts every day. We have a range of colors. We have hoodies, we have mugs, we have hats, we have journals. We have all of the things, and I love having them on because it's just a reminder to quiet the clock, to slow down, to like let life unfold and be happy. So there's meaning and purpose behind wearing it too, which is a nice reminder. So check out our website, quiettheclock.com, to get your merch.
So the purpose of PGTA, or testing for chromosomes, just to clarify, we're only testing for whole chromosomes because patients always come to me and say, oh, I want to do genetic testing because I want to have a healthy baby. But that's not the point of PGTA. We know that as we get older, our eggs age, they have more and more chromosomal abnormalities, which leads to an egg with the wrong number of chromosomes, which then leads to an embryo with the wrong number of chromosomes, which either won't implant or will miscarry. Mm-hmm. There's only 4 syndromes that are described of living that you can live with.
If you guys are like me and wanting to be more mindful about what's in your products, how many toxins are in your products, and making sure that you're putting good things on your skin and into your body, I highly recommend Osea. I did a total revamp on all my products, and this is one I have been using and now is a staple in my bathroom. I particularly love their Ocean Eyes Age Defining Serum. I feel like I don't have bags under my eyes anymore, and I just feel really good putting this on my skin, knowing something good is going on my skin and into my body. So if you want to check out Osea's products, use our code QTCPOD10 to get 10% off your first purchase. I am very excited to welcome back Dr. Anate Brauer. She was here with us for season 1, and I've been dying to have you back on here. So I'm so excited that today worked out. So thank you for trekking all the way here and being with us this morning. And also, I do want to thank you for being such a support for me, even after we recorded and all my craziness and panic moments. I've been able to text you, and you've kind of grounded me and been responsive. And I know you're very, very busy. So I'm not even your patient. And so I just really appreciate that. I wanted to say that here.
That is so kind of you to say. And I'm always here for my friends, my colleagues, my patients.
So when we first had you here, we talked a lot about egg freezing. We talked about the emotional component to egg freezing. You educated us on the process, but I wanted to have you back here to talk all things embryos, because
I love embryos.
I've learned so much through my own journey that I didn't know as someone that, 1, froze my eggs, 2, had a baby. And I think it's really important, even if you're considering egg freezing, to know and understand the second half of it if you have to go back and use your eggs. Because I think, to make the decision to freeze your eggs, it's so overwhelming. The process is overwhelming. It's a lot. And I think for a lot of women doing it to preserve the fertility, they're like, okay, it's done. Put them in the egg, put the eggs in the freezer, and I'm not going to think about it. But I think there's so much to know that I didn't know going into creating embryos, transferring embryos,
Absolutely.
All of the things. So I'd love to talk all things embryos.
Great.
Okay.
I'm down.
Okay. First question would be actually, I have a different question after having a conversation with Dr. Notman, who was here earlier, is she shared with us there is a real consideration for where you freeze your eggs.
Yes.
Because some places, if you need to transfer them elsewhere, will not accept, when you make embryos, will not accept the embryos.
So egg freezing has an interesting history. So I think we shared it in our first podcast that the impetus for freezing eggs really came about in the 1980s, really from Italy, where the church restricts how many embryos you're able to create because of discard reasons. And so the Italians were very motivated to figure out what to do with all the extra eggs, right? If you have 15 eggs retrieved and you're only allowed to create, let's say, 3 embryos, what are you going to do with the rest of the eggs? And that was really the impetus to freeze eggs. And then it was perfected with Japanese and American technology. And prior to 2012, it really was only used under an experimental label for cancer patients. And so only the larger academic centers that could get IRBs to cover this were able to do it. In 2012, the ASRM, which is basically our governing and educational body, lifted that sort of experimental label. And that allowed for industry and private practices to come in and really start to hone the technology. And then it just kind of blew up.
Right.
And so
right.
you'll see that over the last decade or so, there's been a lot more players in the field. The way we freeze eggs also changed. So in the beginning, we were using something called a slow freezing technique, where it's just what it sounds like. You slow freeze over a period of an hour or so. Now we use something called vitrification, which is like a flash freeze. And that's what allows you for better survival rates. But not all centers are created equal, right? Some centers started vitrifying as early as 2008, 2009. Some didn't vitrify. Some very big, well-known centers didn't start vitrifying until 2012, 2013.
Wow.
And so the longer you've been vitrifying eggs and the higher volume you've done, and the more data you can show that says, I can make a baby from these eggs, that's a center you want to find. And it's hard to find because it takes people 10 years to come back to use their eggs.
Right, and so much changes in 10 years. Might not even live in the same state.
Exactly. So whatever center you're going to, because now there's so many startups and pop-ups of centers who are saying, freeze eggs, some even at a discount. You really want to ask, how many babies have you made from frozen eggs? What's your success rate from frozen eggs? And really look at the data, because it's very easy to freeze eggs, but it's not so easy to thaw them and make babies from them. And that's why some centers have restrictions on where we do and do not accept from. Because at the end of the day, if you accept eggs from another center, you're also accepting the liability of were those eggs labeled correctly in the lab and chain of custody, which we take very seriously, and the success rate. Is this egg going to make a baby? And at the end of the day, it's your success rate. So you really want to kind of protect that.
Yeah, and I think that's something a lot of women don't know, and I learned this morning, is that, I guess I did know that some won't accept, but I think understanding why they won't accept and knowing that as you're choosing the place where you freeze your eggs is really important.
And also, there's a lot of women doing this internationally.
Yes.
Which I really recommend against, because
I know you said that.
I promise you that most U.S. centers will not accept those eggs from abroad, mostly because of the chain of custody issues.
That's kind of scary to think about, because I know, at least the women that I've spoken to, or you see women posting on social media about the choice to go internationally, it is a cost effective choice that they're making.
It's tough. Egg freezing, I hope over time, as the technology gets more and more voluminous, usually the cost will go down. Of course, the pandemic changed that with materials, and everything kind of went up. But I think that if you're going to invest in an insurance policy, you want to make sure it's a real insurance policy that you're going to be able to use down the line.
Yeah, and quality at a quality
correct place.
And I think it's important to note too, quality. I know from my experience, like quality not only being technology and testing and data, but also comfort and that emotional piece of being heard and being listened to. And so considering quality in all these realms is really important when you make this choice.
And making sure you're seeing a board certified reproductive endocrinologist. Many of these startups, because they're venture backed, really want to cut costs. I mean, it is a business for them. And so they will hire general OBGYNs because they come at a lower cost. And general OBGYNs are great. Most of my best friends are general OBGYNs. They deliver babies. They do major surgeries. It's not that they're not equipped to do these procedures, but they haven't had the additional 3 years of training and rigorous testing to allow you to do this. And so you really want to be careful where you're going.
Yeah, if I'm trying to be like comparative in my field, I feel like it's similar to, I always think people should get psychotropic meds from a psychiatrist.
Absolutely.
Right, where a lot of GPs are prescribing and can prescribe, but I think it sounds like comparatively it's kind of the same thing. Can you walk us through the process of where, someone's making the decision, like, I want to take these eggs I frozen X amount of years ago and I want to start to make embryos?
Yes. So there's often a misconception that when you're freezing your eggs, you're definitely going to use them. And I think it's important to know that you don't have to go straight for your eggs. Some patients do. If you unfortunately froze them because you had cancer and you did chemo and you no longer have periods, that's one thing. But my perspective is those are there for you as a backup, as long as it's reasonable. So let's say you froze your eggs when you're 28, 30, you come back when you're 35, 36 to use them. You still have good eggs at 35 or 36. So at that point, the place I would start is to just do the testing. So if you're planning on conceiving with a male partner, you would do a semen analysis. you basically do the rest of the fertility workup, the semen analysis. You would look at the fallopian tubes because that's where egg and sperm meet, and the uterus. So we do something called an HSG for that, hysterosalpingogram. It's an x-ray of the tubes in the uterus. And you would reassess your ovarian reserve at that time to see how many eggs do I have left, right? And then quality, as we know, is based on age. And based on all of those things, and also based on how many children you think you want, that's how you decide what are my next steps. Some people may say, okay, everything's normal. I'm going to try for a few months. Maybe I'll try a few IUIs, inseminations of sperm with medication that's a little bit less invasive. Once you end up in an IVF category, that's when you have to decide, am I going to use my eggs, or do I have enough eggs right now? Do I have enough eggs in the freezer and enough eggs right now in my body, and the sperm is normal and everything's normal, that I want to do IVF to create embryos for this imminent baby?
Like a whole new round, leave the eggs in the freezer.
And then leave the eggs in the freezer. But it depends on what you have. If you have 40 eggs in the freezer, you're going to use the eggs in the freezer.
Yeah.
You're not gonna, but let's say you only have 10 eggs in the freezer and you want 3 kids and you're 35 and you still have a decent ovarian reserve and there's normal sperm. I would create embryos for the imminent baby. And then you have the eggs. You can also thaw the eggs and see what you have and take it from there. I'm still a believer in, if someone asks me what's the best way to get pregnant, I would say as naturally as possible. And that's why I still recommend that my patients try on their own. Like, the eggs are in the freezer. You have that as a backup.
I know. I get this question a lot because I did go right to the eggs, and I didn't even think to start trying. I don't know. I can't even. We didn't even try naturally. I mean, I got naturally pregnant at 39. But I went right to the eggs and the IVF, and everyone's like, "Well, why did you do that?" And I'm like, oh, "I don't know. It didn't even." I guess maybe too, the narratives around my age. At that time, I was 42 when we.
Right. That's right. All of these things. First, it's important to understand that there's no one way to do things. That's what I love about my field. There's so many paths to get to where you want to get to, and there's no right or wrong answer for anything. And so, yes, if you're 40, 41, I mean, you're probably going to go for the eggs, because you know that 90% of your current eggs are chromosomally abnormal, and you just want to know what you have.
Wait, what was that percentage?
About 90.
90?
About at 40. 85%, let's say. Didn't we talk about that last time?
I don't. Maybe I'm just more hyper in tune with those stats now that I'm in that camp. Wow. Oh my gosh.
But you want to know what you have in the freezer, because what you don't want to do is keep your eggs in the freezer as eggs. Let's say you turn 40 and you have eggs in the freezer. You don't want to try on your own for a year. Now you're 41 and then you thaw the eggs and you find out you have nothing.
Right, exactly.
Right? Because that's not good either.
Right.
So you want to, that's what I mean. There's so many factors that go into it. What you view as a complete family. By the way, a note about that. I ask my patients that at every new patient consult, what do you view as a complete family? And my patients who've been struggling with infertility always say, well, I used to want 3, but now I'll settle for 1. And I always say, and I really believe this, never settle.
Yeah.
It's like negotiating for a contract. Just tell me, what is the ideal situation, and we'll work backwards from there.
I think that's the mindset thing that applies to all parts of life, is that the scarcity mindset, or the settling mindset, whether that's with, relationship or with work. I think we often can't give ourselves permission to kind of dream big, and we have these limiting beliefs or scarcity mindsets that inform a decision or an answer that's not really aligned with ourselves. I love the question, and I didn't get this question when I was egg freezing, but the question of what do you want your family to look like, or how many children do you want? And we had a guest on at her egg freezing consult that was the question, because they said you might not need this for your first or your second, but if you want 3, and I thought that was incredible, because I was never, asked that question. I never thought about it in that way. I think when I was doing it was that scarcity mindset, I have to do this, I have to do it now, I have to get eggs. And I wasn't even thinking about I want 3 kids. I love that that's part of the consults.
Yes, absolutely. It's not always part of the consult, but for me, I find it just helps planning with the patient.
What other, you mentioned some things, but what are there besides semen analysis, fallopian tubes, what is standard for preparation?
For an embryo transfer.
Mm-hmm.
So with an embryo, now let's say you've tried on your own, you've done the IUIs, whatever. You've decided to thaw the eggs, fertilize them. I'm sure we'll talk about all those steps.
Yes,
right?
yeah. Wait, let's go back. Let's do those steps. Yeah. I jumped ahead.
So now you decided to thaw the eggs. We thaw them, fertilize them with sperm. There's actually 2 ways to fertilize eggs.
Really?
Yes, but with frozen eggs, you don't have two choices. It's just one way. But in general, there's two ways to fertilize fresh eggs. There's conventional insemination, where you put an egg in a droplet and you surround it by 50,000 sperm and let them do their thing. Or there's something called ICSI, intracytoplasmic sperm injection, where you take an egg and you inject it. You take a sperm and you inject it into the egg. If you're using frozen eggs, you have to use ICSI.
Okay.
You cannot do conventional insem because the eggs have been stripped and frozen, and they have kind of hard shells, and you need to get through that. So now you have, the day of your egg thaw, you get called usually with how many survive the thaw. So some percent you will lose. Usually it's about a 85 to 90% survival rate.
Can I ask you another question before you keep going forward? When you have fresh eggs, is there a better option in terms of fertilizing? Is one option better than the other?
They're pretty similar to each other. There's some labs that do 100% ICSI. There's some labs that only do ICSI for strict criteria. So strict criteria is severe malfactor, meaning very low count or motility of sperm or morphology, less so morphology, but you can use that as a criteria as well. Other hardline criteria for ICSI are frozen eggs and PGD, pre-implantation genetic testing diagnosis for specific diseases, also known as PGTM.
Okay.
So if you are looking for a specific disease in embryo, you have to use ICSI because you cannot have any extra DNA contaminating the sample. So those are the hardline reasons to do ICSI. Some labs do them 100% because it's very hard calling a patient the day after retrieval and saying you had no fertilization and you didn't expect it, and we'll do ICSI with your next case. So that's a controversy. That's a podcast in and of itself.
Oh, really?
Which
Okay.
you should totally do. Okay. There's a lot of debates about that. So maybe I'll hook you up with an embryologist.
Yes,
we can discuss.
Please.
But so now you know how many got fertilized. And then we grow them to what's called a blastocyst. A blastocyst is an embryo that has two cell layers. It has an inner cell mass that becomes a fetus and an outer cell layer that becomes a placenta. And they're genetically equivalent around 99% of the time. Okay. It takes about 5 to 7 days to grow a blast. We'll talk about grading in a little bit.
I do. It's a question here. Yeah.
So 5 to 7 days to grow a blast. And then you can take some of the outer layer cells that become the placenta, freeze the embryos, send the cells off for testing. You get a report back around 2 weeks later with each embryo and its chromosomal complement. And now you know which is normal and which isn't.
What is like I don't know if this is the best, is day 5? Where do you want them to land? Day 5, day 6?
Yes. So let's talk about grade. You want to talk about grading quickly? Okay.
Yeah.
So when we look at grading, we basically look at 3 things. We look at the day at which it became a blast. So we're always going to go for the day 5s before the day 6s, before the day 7s, because it developed in a more typical way, right? You want to see a blast on day 5. Now, there's some nuances there because when you're doing PGD or PGS, or when you're doing PGTA, testing of the embryo, it has to be expanded enough in order to do the biopsy. So let's say the embryologist looks at it. Let's say you're in a lab where they only look at the embryos once a day because every lab is different.
Oh my gosh, that's
So let's
interesting.
say they look at the embryo at 10 a.m. That's when they look at their embryos. And it's not quite expanded enough to be able to safely biopsy, right? Because you only want the outer cell layer. You want to leave the inner cell layer alone. That becomes
That's
a fetus.
the baby, yeah.
And so let's say at 10 a.m. it's not quite expanded yet, and you don't look at it again until the next day. Now it's a day 6 blast.
But potentially later in the day could have.
Had you looked at it at 5 p.m., maybe it would have been a day 5. And so the question becomes, does it really matter if it's a day 5 or day 6? And actually there's studies, we used to think it mattered, and then studies came out that if you have an embryo that's a day 6 that came from a batch that had day 5s, the success rate is the same.
Oh, interesting.
Yeah. Okay. So to me, a day 5 and day 6 is very similar. So a day 7 took a little bit longer to develop, and we used to never even test day 7s. We would discard them.
Really?
But then we found that they make babies and pretty significantly, right? So a day 5 or day 6 embryo that's euploid has about a 60% chance of success. Day 7 takes a bit of a hit, probably like 50%. If you have a day 7 that's a lower grade, we'll talk about grades in a minute. Yes, it takes even a bigger hit to about like a day 7 CC, I'll talk about that in a minute, is about, let's say 40% pregnancy rate, but still 40%.
It's something.
Significant, right? So I'm a big proponent of testing day 7s. And I've always worked in a lab that does.
Okay, that was going to be my question. Are there some labs that still won't
Some labs still won't.
And that's a good question to ask when you're 100%. Considering where you do your embryo making. I would want to be at a lab that does day 7. I want to have as many possibilities.
Yes. Agreed. I think that labs that are kind of up to speed on latest technology are testing day 7s. In New York City, I hope that everyone's testing day 7s, but not everywhere in the country. Okay, so that's day. So that's the day when you hear day 5, day 6, day 7. The second part is either a number grade or some places use a descriptive grade for how expanded the blast is. So it can range from 3 is not expanded at all. So the progression of an embryo is you have one cell that has 2 nuclei, a nucleus from the egg and a nucleus from the sperm. Then it starts dividing. So if you look at an embryo on day 3, it's in what's called the cleavage stage, which means you can count all the cells in it.
Okay.
So they can't give you a grade on that. They just say it has 8 cells, it has 9 cells, and they give you a percent fragmentation, meaning are the cells whole or are some of they fragmented? You can't really grade day 3 embryos, which is why so many centers have stepped away from transferring day 3 embryos because you don't know anything about them. Okay. Then the cells come together, they start compacting together. Then it becomes what's called a morula. A morula is like trying to make a blast. Then it makes a blast. And the first stage of a blast is you can either call it an early blast or you can call it like a 1, 2, or 3 blast. 4 means it's an expanded blast. 5 means it's a hatching blast. And 6, the number 6 means it's hatched, like it's already hatched. Some labs, like before I was at RMA, I was at Shady Grove Fertility, which has many, many labs. And some of the labs use a descriptive grade. So they'll say early blast, EB. Or they'll say XB, expanded blast, or HB, hatch blast. And so
where do you want it to be? Like, what's the best?
4, it needs to be at least a 4 to be able to test it.
4, okay.
4 or 5 is ideal. 6 is fine. The hatched ones, they are the most progressed, and it's great that it's hatched, but they're a little bit more fragile. So they're a little bit harder to handle. They're more likely to get retained in the catheter because they're very sticky.
Really?
Yeah. So they're just a little more sensitive. It doesn't mean that they have a lower success rate.
Wait, what do you do when that happens? When
you just do the transfer again. I had one the other day, actually.
Really?
I have them like once every 2 years. I don't
know. Do you panic when that's
No, you just hand it back and hand back. So when you're doing a transfer, we'll get to this later.
I know we're jumping ahead. I was just, I couldn't believe, I didn't even know that was a thing that it would get retained in the catheter.
So they flush the catheter. We leave everything in place and then they flush the catheter and then they say clear. And when they say clear, we can take the speculum and everything out. But sometimes they say, we still have an embryo.
Right. I remember that from the transfers, like the clear.
So where was I? So so you have the days, which is 5, 6, and 7. You have the number, which is how expanded it is. And then you have the grade. So the outer cell layer gets a letter grade and the inner cell mass gets a letter grade from A to D. So the most perfect blast you'll ever see is a day 5, 4 or 5 or 6, but they're a little more sensitive, AA.
Yeah.
But those we usually see in like 20-something-year-olds or donors. So to me, if I see like a BB embryo, that's a wonderful thing in most of my patient population.
I think like the number with egg freezing, like the numbers where we get so stuck on that, women can get really stuck on the grading. And I think there is, you tell me, like some conflicting conversation about the importance of grading. Like some doctors will say the grading doesn't matter as long
embryos.
Of embryos if they're
euploid.
tested,
yeah.
if they're, and others will say differently.
I don't totally believe that. I mean, of course, a euploid embryo is a euploid embryo, but we know that a day 7 CC embryo has a lower success rate. And so do I think there's a difference between a day 6 BB and a day 5 BB? Probably not, if they're both euploid. But once you get into the, into the C range and later on, they do take a little bit of a hit.
Yeah.
And there's data on that. I think the difference between day 5 and 6 is a little less so. And that's because of what I talked about. But I do think it matters.
It's so hard because there's just so much information out there. There's so much information that is not credible. There's so much information that is conflicting. So it's lovely to have reputable source helping us here.
And what's also interesting is, there's still a controversy between testing or not testing embryos, right?
Yes, let's talk about that.
Yeah, so the purpose of PGTA, or testing for chromosomes, just to clarify, we're only testing for whole chromosomes because patients always come to me and say, I want to do genetic testing because I want to have a healthy baby. But that's not the point of PGTA. We know that as we get older, our eggs age, they have more and more chromosomal abnormalities, which leads to an egg with the wrong number of chromosomes, which then leads to an embryo with the wrong number of chromosomes, which either won't implant or will miscarry. There's only 4 syndromes that are described of living that you can live with.
I've learned all of this since my
Right.
Yeah.
So so it's an extra. They're chromosomally linked. So there's a whole chromosomally link. An extra chromosome 21 and is Downs, an extra 18 is Edwards, an extra 13 is Patau's, and missing an X chromosome is Turner's. Everything else will miscarry or not implant, and most of those will also miscarry or not implant. And so the goal of the testing, the purpose of the testing, is to find the best embryos sooner, to try to maximize efficiency to pregnancy.
Yeah.
And also to decrease miscarriage rates, because it's the biggest reason for miscarriage is a chromosomal abnormal embryo. So that's the purpose of it. The con of the test is that it's not a perfect test. It has a 1% error rate, right? That's significant.
Yeah.
And also, sometimes you get results you don't know what to do with that are very frustrating. So you can get something called a mosaic.
I was going to ask about mosaics.
Yep.
Yeah.
So mosaic is an embryo that has some normal cell lines and some abnormal cell lines. You have to realize you're taking a few cells. Let's say you're taking 5 cells from the outer cell layer that becomes a placenta. You're then amplifying the DNA, and that's what you're testing. So there's a lot of room for error there. So mosaic has some normal cells and some abnormal. We used to not even transfer mosaics. Now we know that low-level mosaics, which means 20% of the DNA is chromosomally abnormal, has a very similar implantation rate to euploid embryos.
Wow.
And so now we're transferring them. We're not transferring all of them. We're still a little bit apprehensive with, the 21s and the ones that we know are described out there. But we're learning more and more. At RMA, we actually have 2 unbelievable genetic counselors. I mean, 2 of the smartest people you'll ever meet,
Wow.
Teresa and Donnie, big shout out to them. So any of our patients who have mosaic embryos, meet with them and decide, do I want to transfer? Do I not? What are the implications? What do we know about this specific mosaic?
Yeah.
And then sometimes you'll get an embryo that's no DNA detected. It doesn't have a result.
Really?
Yes. And so in those cases, you have the choice of just treating it like an untested embryo and transferring it, or retesting it, rebiopsying it. And every time you rebiopsy an embryo, there's potential to risk losing the embryo or what have you.
For patients that some are choosing not to test, what are the reasons that they maybe choose not to test?
A lot of it is cost. It's usually cost. And then there's a subset of patients that it's religious and ethical. I don't want to know because even if it was abnormal, I'm not going to discard it. And at the end of the day, no reputable center is going to transfer a totally chromosomally abnormal embryo, an aneuploid embryo.
Talking earlier, I'm just thinking my own experience. Talking earlier, one of the other categories is aneuploid, which is not
chromosomally abnormal.
Yeah, and so when I transfer my embryos, the lab that we're going to wouldn't even take those. They would only take.
Correct. They'll only take. And if you're transferring embryos in and out, most labs also will not accept other labs' mosaic embryos.
Really?
Yes, which is a huge issue.
That's important to know too.
Yes.
So yeah, we're learning a lot of great questions to ask before you even choose the place.
Correct.
Where you make your embryos.
Yes.
Okay, so I'm going to speak for myself here because I learned so much about my body and things that were happening in my body post 2 failed transfers. So my frustration with that is, why weren't some of these things done before? And I know I did them at 2 different places, so it's not totally fair to put blame somewhere, but things that my current doctor tested for after my miscarriage was she did a full thyroid panel, not just, I want to talk about THS.
Okay, sure.
And I think I shared this with you, that my thyroid antibodies were through the roof. And then we recently did a uterine biopsy where I had a chronic infection. So those 2 things were done. And I don't know if those are the things that caused my miscarriage, but those were 2 things that were done after 2 transfers. I'm just curious.
Yeah.
Are those things that patients can advocate to have done before any transfers?
Let's talk about that.
Yeah.
I call it the rabbit hole of testing.
Okay.
Because it's a rabbit hole. So first, if your first transfer in, the basic things that you need to do are a saline sonogram. So it's a 3D. We basically put a speculum in, put a catheter in. The catheter is a trial transfer catheter. So we kind of make sure that the embryo is not going to have a bumpy ride. We don't want any surprises on transfer day. And I'll talk about different ways to do transfers too in a minute. So you do that. And then you also infuse uterus with saline, and you take 3D pictures of the uterus to make sure it's a happy home for an embryo. So that's everyone does that. All the other preconceptual testing you want to have up to date. Thyroid, prolactin, if you have irregular cycles, if you have regular cycles, prolactin's kind of falling out of favor, but a lot of people still do it. Making sure you're immune to things like rubella, varicella, making sure your vitamin D is where it needs to be.
And that's all blood work, right?
All blood work.
Okay.
I would definitely be on a prenatal vitamin as you're preparing, and vitamin D if you're deficient. All of these things you want to kind of have set up. Then there's 2 different ways to do embryo transfers.
This was a question of mine too.
Well, it's like a progression. So I'm going to take you through the progression.
Okay, but one more question before.
Yes.
So the thyroid, the blood work for the thyroid, you're only testing the TSH.
TSH. So TSH is thyroid stimulating hormone. It's a hormone that your brain makes that tells the thyroid to make thyroid hormone. If your thyroid is underactive, your brain has to work harder to make more thyroid hormone. It's actually very analogous to FSH, that is the hormone your brain makes.
Which you explained to us last time, yeah.
So TSH is the best marker for hypothyroidism or hyperthyroidism. This is what we use as a marker to see if you're responding to medications. And if you're hypothyroid, we do thyroid replacement. We give you Synthroid. And so if your TSH is normal, and by the way, we like to keep it under 2.5 for anyone trying to conceive. If you look at the range on Quest or LabCorp, or even if you talk to a PCP or a medical endocrinologist, they're going to tell you it's fine if it's under 4. But for us, we like to keep it under 2.5 because there are some studies, again, a little bit controversial, but it's pretty well accepted now that you can potentially increase your risk of miscarriage if it's over 2.5. So we like to keep it under 2.5. For my patients, if there's anything over 2.5, I usually treat, and I reflex like a full panel.
How long do you treat for before?
I want it to normalize. It takes about 6 to 8 weeks to normalize. TSH lags behind a lot.
I'm so frustrated because I know I texted you this, but mine was 2.9 the day before transfer, and they told me it would be fine to transfer.
Yeah, so I would not. I mean, again, this is data that can be controversial. And the question is, like, is there really a difference between 2.9 and 2.5? I mean, actually.
But I think giving that woman that choice, right? Like,
I would treat.
Yeah.
Personally.
Yeah.
But I'm a little more aggressive in that way. Then there's a subset of patients. So then more studies came out, by the way, that said, okay, it's fine if it's over 2.5 if your antibodies are negative.
You texted me that. Yeah,
yes.
yeah.
But if your antibodies are positive, then it increases your miscarriage rate.
I just think it's good information so that a woman can advocate or just ask more questions, like 100%. Which I didn't have. Like my whole first, and I do want to talk about the different ways, but my whole first transfer, I knew nothing. I had no. I went into it very naively and ignorantly, like I didn't know.
Wait, did you say your TSH was 2.9 the day before the transfer?
Like a couple days before. My last blood draw was.
Were you already on estrogen?
No. I wasn't.
Because that's another thing. It makes me crazy when my nurses accidentally send an updated TSH when my patient is about to have a transfer, because estrogen, and this study came out of Penn, estrogen can falsely increase TSH levels.
I wasn't. So my question, and I think you're getting to this, one of my other questions is, how do you choose a medicated cycle versus unmedicated cycle? I wasn't on estrogen. I was like, all I did with that one was the progesterone suppositories. I wasn't on estrogen.
Okay, so you did a natural cycle.
Yeah.
Yeah, so we'll talk about that. But back to the TSH, there's also a subset of patients who have a normal TSH but have elevated antibodies. So those patients will eventually develop hypothyroidism, but that's a tough category of what do we do with this patient? We usually send them to medical endocrine, and sometimes they'll treat just kind of preemptively because in pregnancy, everything goes haywire anyway with TSH. So you want to get all of that stuff checked. Okay, then there's 2 ways to do transfers. Programmed frozen embryo transfer cycles or natural. Programmed is like 90+% of cycles. Most places do mostly programmed, and that's because it's very low maintenance. It's extremely scheduled. Most people want their doctor to do their transfer. You can almost guarantee it. There's very few appointments. So you get a period, you come in for your baseline ultrasound. If everything looks good to go, you start estrogen. You're basically mimicking your cycle. So you take 2 weeks of estrogen to thicken the lining. Once the lining looks good to go, you start progesterone, which has to be injectable if you're doing a program cycle. It's intramuscular.
Okay. So not the suppositories.
Intramuscular progesterone. And then the transfer is done in the same way on the 6th day of exposure to progesterone.
Okay.
Right? And the transfer itself is put a speculum in, 5-minute procedure. It should always be done under ultrasound guidance. Another thing we can talk about, because not all centers do that, which to me is wild. because they don't have the staff or they think it doesn't change outcomes. But at the end of the day, it's such an easy thing to do just to make sure you're dropping off the embryo at the right place.
I was going to say, how do you know where it's going?
Away. It doesn't stick right away, right? Because it floats around for 3 days or so until it implants. But at least you're not too far up. You're not, touching the top of the fundus with your catheter, all of which are things that negatively impact pregnancy.
So that's another question women should ask is, do you do the transfer under ultrasound?
Yes.
Yeah.
There is still one major center in the city that does not. I'm not going to name names, but
People do your research.
I have many colleagues there, and I tease them about it all the time. But I just think it's and they're basically like, well, we've had great success rates, doesn't change outcomes, but it's such an easy thing you can do that we know can potentially impact.
I think that to live in too much gray for these procedures,
Yes.
I would rather be kind of on the mark with the things that we know
100%.
work. Like I don't feel comfortable with it shouldn't really matter. It should be fine. Or I don't want to live in that gray for something like other
Absolutely.
ways in life. It's okay to get comfortable in the gray, and I'm a therapist. I believe in that. But I think for something like this, I don't want gray. I don't want 2.9, it's fine. Don't worry about it.
Yeah. There is a lot of gray in what we do, though.
I know, but if I had
so frustrating.
If I had
minimize the gray, you want to minimize the gray.
Minimize the gray. Yes,
Yeah,
that's a great way to put it.
So that's a programmed transfer. Most places do it that way because of scheduling and also for the lab, right? The lab needs to know their schedule. If it's a busy lab, at RMA, we're doing 15, 20 retrievals a day.
Wow.
You want to be able to plan things. We still do natural cycles if we need to, and the success rates are really great, right? And the success rates for the two are the same. If you look at the data that's out there, they're pretty much the same. Okay, a natural cycle for an embryo transfer, you do not start with estrogen. You're kind of letting her grow. You're growing a follicle, and that follicle you make your own endogenous estrogen that thickens the lining. Then you trigger ovulation. Some people just wait for ovulation. I prefer to trigger because it allows you to schedule somewhat, and also you're just more specific with your timing of when you're starting the progesterone. So you trigger and then you start. You can either do intramuscular or vaginal. A lot of people choose vaginal, or some people hate vaginal progesterone, by the way. It can get kind of goopy and gross. And so I give my patients both options. And you still do your transfer on the 6th day of progesterone exposure. Natural cycle protocols differ from place to place a little bit, but interestingly, the success rates are pretty similar. So I think it makes a huge difference. But I do it on the 6th day of progesterone exposure.
Is there a reason, if the success rates are the same, is there a reason that you might choose one way of doing it for a patient versus another?
Yeah. So my patients who can't tolerate the intramuscular progesterone, some people have severe allergic reactions, or they just have a lot of pain and they can't, I'll do a natural. The caveat to natural is you have to have regular cycles to be able to do it. If you don't, you can also get away with doing something called a modified natural, where you give someone letrozole or Clomid to try to get them to grow an egg to ovulate, and you're using that egg. But in general, you want to have regular cycles. Also, my patients who can't take exogenous estrogen, so I see a large subset of former breast cancer patients who have now survived and they want to carry on their own. Listen, they're going to have 10 months of estrogen exposure, but I just try to minimize the exogenous with them. Patients who have any kind of medical issue where they just cannot take exogenous estrogen, we do a natural cycle.
Gosh, so much information and so much.
Oh, and so now we'll get to the failed transfer conversation.
Yeah, that was my.
So this is where I was going with the natural versus program. So if I have a patient who fails a program cycle, right? So 60% of people will succeed, 40% will fail. So why does someone fail a transfer, right? It's either the embryo or the environment. You've tested the embryo as much as you can, right? You've done PGTA, you've done everything you can, but it still has a 1% error rate. And it's only testing for whole chromosomes. You're not looking at small deletions and duplications that could still be the issue with the embryo. Environmentally, I mean the environment of your uterus, right? You're making sure the lining looks good. You're making sure estrogen and progesterone look good. Thyroid, we won't go there. All of those things, right? You want to make sure all that looks good. You do the saline. And so, but a lot of times it's just statistics, 40% will fail. And so in my patients who fail a program cycle, and some people think, some people think this is a little too aggressive, but I usually will offer a natural cycle next, just to do something a little bit different.
Why do people think that's too aggressive?
It depends on the colleague you speak with,
Yeah,
right?
okay.
So centers that don't like doing natural cycles think, why are you jumping to a natural cycle? Like the program failed, 40% will fail. Like, it's just one transfer. But for me, if I were the patient, I would want something different.
Same. Oh,
And
yeah.
so I would do a natural.
Yeah. Yeah.
Especially in my secondary infertility patients who got pregnant previously, easily. I think a natural cycle is a great option because your body did it before. So you must be making enough hormone.
How hard is it for you as a doctor to, one, deliver that news, and two, terrible, I imagine, and two, maybe have gray answers for why it didn't work?
So people who become doctors because we like certainty and science and statistics. We do not do well with uncertainty. And our field is all uncertainty. Pregnancy is uncertainty. Anything can happen in pregnancy, even if you're 39 weeks.
I know.
And so it's very hard. And it will never get easier to deliver bad news. I think it actually gets worse because you develop a connection with these patients, and not everyone is like this, and it's like a problem. I need a therapist for it. Actually. Any good ones? I internalize the bad news. Like, I know the statistics. I know that 40% of the people I call are going to be bad news, but I still feel like it's like my fault and like, what could I have done differently? Even though I know the statistics, right?
Yeah, but that's like your logical, rational mind, but your emotional mind.
My patients always joke with me that like when I call them, they can tell from this how I say hello what it's going to be. And I feel like we're like really riding that roller coaster with them. It's like a failure for all involved, And so, and it's hard because the answer is, I don't know. It is very hard for someone to say, I don't know. I think it's really important for doctors to be able to say, I don't know. There are doctors who can't say, I don't know. And that's not good either. But sometimes it's, I don't know, let's try it again. Let's try something a little bit differently, like a natural cycle. And then, so with the second transfer, now you should have a cumulative pregnancy rate of 85%, meaning 85% of patients should be pregnant after 2 embryo transfers, whether it's programmed or natural or whatever it is.
Meaning third embryo transfer should work, or meaning the second?
Now you're in a 15% category of people who fail 2 consecutive transfers.
Okay.
So this is when I start to bring up the rabbit hole of testing, which is a uterine biopsy for a potential of 3 tests. Testing for something called CD138, which is a marker for a chronic asymptomatic infection, chronic endometritis. This is what you were referring to earlier. And by the way, all of this is controversial. So I'm going to tell you what the tests are, and then I'll explain why they're controversial. Okay. So CD138, something called BCL6, which is a non-specific inflammatory marker. It's a test called Receptiva. I do not work for the test, and I don't even know if I believe in the test, to be honest with you. However, I offer it. It claims to pick up things like silent endometriosis or hydrosalpinges, which is fluid in the tubes that causes inflammation. Although if you had a significant hydrosalpinge, you would see it. You'd also see it on an HSG as well. But for me, if someone's failed 2 transfers and now in their 15% category, even though it's very nonspecific, I test it. The last is called an ERA, an endometrial receptivity assay, which we could do an entire podcast on because it's a test that we used to do all the time. It basically tells you, we have a very specific window of implantation that's based on hours of exposure to progesterone. So for most people, being transferred on the 6th day of progesterone, for 90+% of people, that is their window of implantation. But there's a small subset, or the test argues that there's a subset of patients that need more hours of progesterone exposure or less hours. And so
day 6 might not be the right.
So you basically do a biopsy on the day that you would have done a transfer. Right? At that moment where you thought and then they analyze candidate genes that say it's receptive or it's pre-receptive or it's post-receptive. Now, when I was at Shady Grove Fertility, which I'm still part of the network, we're part of a bigger network called US Fertility that RMA and SGF are both a part of, but my colleague Nicole Doyle, who's amazing, if you ever want to talk to her, she published the study that we actually co-sponsored with iGenomics, who are the makers of the test. There was a randomized controlled trial, first of its kind, around 1,000 patients, all comers with a euploid embryo, randomized to doing the ERA testing or not. And we basically showed that the test does not change outcomes at all.
Whoa.
However, that did not incorporate patients with recurrent implantation failure.
Oh.
Okay. So for my recurrent implantation failure patients, I still offer them the test. If the first test comes back positive, the CD138, it's easy. You take antibiotics for 2 to 3 weeks. Usually it's doxycycline. You have to stay out of the sun. Like, it's annoying, but you do it. BCL6, this marker for nonspecific inflammation, which, by the way, comes back positive in about 70% of patients.
Whoa.
But if it's positive, then you have to do what's called Lupron. You shut down the whole system, right? You shut down your brain for making FSH and LH for usually 2 months.
Whoa.
It's like almost like a chemical menopause. I usually overlap it with letrozole to just have total suppression with the thinking of, and that's how endo is treated too, right? You just suppress everything. And then you do a transfer after those 2 months. Again, the data, it is not a very evidence-based test, meaning there are not large randomized control trials. Anecdotally, I have had success with the test, and so I always offer it to my patients. They should at least hear about it.
Exactly.
If they don't hear about it from me, they're going to hear about it on Instagram, which is a bigger problem.
Instagram, Google, TikTok. Yeah.
So that's BCL6. And then the ERA, which I've done less and less of, to be honest, because the question with ERA is, what I really care about the ERA is if it's post-receptive. If it's pre-receptive, I don't care. So many patients come back as pre-receptive. And, I was trained by Zev Rosenwax at Cornell, who always said to us, the embryo and the lining has to be in sync. The embryo can wait for the lining, but not the reverse.
The other way around.
If you put it in a little bit earlier, it's okay, but you can't put it in later because you've missed your window. And so if I get a post-receptive test, I'm going to do something about it.
But pre-receptive, it wouldn't.
Pre-receptive, my argument is this is one data point versus millions of data points that are telling you should put it in on day 6. So are you really going to put it in later, which is kind of detrimental based on this one data point? That's a really hard sell for me. So if it comes back as pre-receptive, and by the way, before I do any of this testing, I counsel my patients extensively. And I'm honest with them, like, this is not evidence-based, but we have this option and this is what would happen if it came back positive. Sometimes it comes back positive and we decide not to treat. If it's a very low positive, it's always a conversation, but you should at least there's other tests, Emma and Alice, there's a million tests. Yeah. But those are the 3 that I offer.
But I think what you said too is just giving the option and giving the information and letting the patient decide what feels best for them is most important. Okay, you have schooled us with so much amazing information, so many things I'm learning today. Any last thing you want to share before we wrap up?
It's already been an hour. There's so much to talk about.
I know, you have to come back.
Last thing I want to share is I think it's really important to be your own advocate.
Yes.
Moms or future moms always have an instinct. And if you feel like something is off, or if you feel like you want to ask a question, it's just important to ask it. And it's important for you to have a relationship with your provider where you can ask it. And the second thing is, and I say this all the time, I said this to you before we started, I really believe that we are meant to have the babiys that we have when we have them. I really believe that. Yeah. And so just remember that, when you're going through all the BS of
staying grounded in that is so important. Yes. One last question, because what you just said prompted me to ask something else. Because as a therapist, I think sometimes when you're in the client side, you don't know what the therapist is thinking. You don't know what's okay to ask or not ask. And as therapist, I think anything is fine. If you don't like what I said or your session was hard, like, we really do want to know those things. And I think it's important that clients know, like, we do want to know those things. You don't have to, make a story up in your head that, like, I'll offend my therapist. So my question is to you, do you like when patients are asking lots of questions? That's good to know.
My patients come with notepads with a million questions and they apologize before they ask them.
Yeah, of course. Yeah.
And I feel so bad for that. I mean, I try to be, as open as I can to say, you can bring me all the things.
But not everyone's, I'm uncomfortable. I go to I first of all, I avoid doctors. But when I do go,
I'm a doctor that avoid doctors.
When I do go, I'm doing the same thing.
Yeah.
Like, I'm a doctor. Like, I don't want them to think I'm stupid for finding this thing on the internet. Like, but
I know. I feel like it is like just moving through that discomfort, knowing doctors don't mind that you're asking questions and ask all the questions.
Yes.
Thank you. I know it's a lot to get here, but I appreciate you being here.
Absolutely.
And we always love having you here. So you're always so welcome back. We want you to share. There's so much more to talk about.
Thank you so much for having me.
Thank you, Anate. Thank you. I think it's no secret that I love the Little Words Project bracelets. I have about 6 or 7 on my arm, ones that have been given to me, ones I've bought myself. I love giving them as gifts. I think they're so inspirational for me personally. They're nice little reminders throughout my day to have hope, to be, have strength, to be in good energy. I just love the bracelets so much. I love giving them. I love receiving them. And if you want to check them out and you want to give it as a gift or get one for yourself, you can use our code QTC for 15% off your first order. Hey guys, I'm Beth. Thank you so much for tuning in to Quiet the Clock. If you want to hear more episodes and learn more about how to dismantle societal timelines, live life on your own terms, live life fully and authentically, subscribe to our channel on YouTube, and you can also follow us on Instagram and TikTok at Quiet the Clock Pod.